Well, good evening, everyone. Welcome to this evening's TUGS session from the subspecialty chapter of Emergency General Surgery and Major Trauma. And the topic for this evening is on major trauma, and we aim to hopefully comprehensively cover the management of rib fractures in the context of major trauma. We've got two excellent speakers this evening. I'll introduce our first speaker, but before I do, if you have questions, then please use the message facility and send them. And once the two speakers have given their presentations, we will aim to cover any questions at the end. We have built in some time and we shall be finished within 60 minutes. So without further ado, I'm going to introduce Kerry Battle. If anybody has any interest in academia for rib fractures, almost certainly you will have come across Kerry's seminal paper on how to score rib fractures. Her academic output speaks for itself. She is a consultant physiotherapist who works in the Morrison Hospital in Swansea. She's an honorary associate professor at Swansea University. She's a specialty lead for trauma and emergency care research for the whole of Wales. Her main research interests are the management of blunt chest wall trauma and in particular risk stratification within the emergency department. Kerry, over to you.
Thank you very much. All right, here we go. I'm going to share screen. This is always the worst bit of any talk, isn't it? Hang on. Right, can you see that?
Yes.
Yeah, we're up. Okay, so thank you very much for the introduction, Michael, and also thank you for asking me to talk tonight. So just to start off by saying I've got absolutely no conflict of interest, nothing, I'm not that interesting at all, but I am funded by Health and Care Research Wales on behalf of Welsh Government. So I always like to thank them at the start of the talk. So the STUMBL score, so this is my risk stratification score, or I should call it the battle score, I think, otherwise Michael will be interrupting me. So why the Leonardo da Vinci quote? So simplicity is the ultimate sophistication. Well, the STUMBL score, the battle score, is a simple risk stratification tool, and I'll demonstrate what I mean by that throughout the course of the presentation. But I think that's really key to the score and to its apparent success. But I'm going to start off with a brief case study just to set the scene, which may ring true with many of your own experiences. I think most people, most clinicians have had at least one of these experiences. So basically what started this work was a patient presented to our ED many years ago now. When I first started this, about 15 years ago, and it was a paramedic who'd recently retired, who was employed by our health board. He'd gone out, he'd slipped on ice and he'd fallen, and he had fallen on his chest wall. And he presented to our ED with complaining of just discomfort on his chest wall. So the usual sort of pain, difficulty taking a deep breath, and doing a cough. We chest x-rayed him, saw a couple of rib fractures, gave him analgesia and sent him packing, sent him home, discharged him. And over the course of the next couple of days, he actually represented to our ED now with severe breathing problems. And we CT'd him this time, and we actually found that he had 5 or 6 quite displaced rib fractures and quite a severe haemothorax at this point. Eventually came up to our critical care unit where I first met him, which is where I worked at the time. And to cut a very long story short, this gentleman over the course of the following month developed quite severe pneumonia, empyema, and sadly we lost him. And it just seemed to us what could have been so easily perhaps avoided if we had admitted this gentleman in the first place and monitored him more closely. And it really started us thinking, you know, where are we going wrong with these patients? But so why prognosticate at all? So why do we not just treat what we find when the patients come into the ED? Well, Hippocrates was the first recorded physician to document that prognostication is an important component of medicine, not just the treatment and the surgery. And he also pointed out that the patient factors were as important as the disease itself. So there's just a few things we're really certain of with blunt chest trauma management. Firstly, what we know is that these patients often present very early after the injury itself because they're so painful, but complications don't really set in until around 48 to 72 hours post-injury. So prognostication can be quite difficult, and that's well known. And then secondly, prediction models are now shown to be superior to clinical examination alone, and especially the ones that guide management, so the decision tools, rather than just give a risk of a particular poor outcome like a prediction tool would. So a good decision tool will not only predict risk, but it will also guide the clinician and help make a decision with regard to management. So whether the patient, for example, could be discharged home from the ED safely, or whether they need admitting to a ward or to a higher level of care, perhaps such as critical care. But it can also potentially direct other management decisions, such as need for regional analgesia, surgical intervention, or perhaps need for long-term follow-up. So the STUMBL score, as you hopefully can see on this slide, I've taken this from the Pan-London Trauma Network guidance. They've illustrated the tool better than I ever did, in fairness. And these are the variables that are actually important to the patient and when risk stratifying using the STUMBL score or the battle score. So age of the patient, you give 1 point for each decade. The number of rib fractures, so 3 points per fracture. And then obviously incrementally goes up with the number of fractures. Whether the patient has chronic lung disease or not pre-injury, that would score 5. Whether the patient's anticoagulated or not pre-injury, that would score 4. And then the oxygen saturation levels. And we tend to take this as the first saturation level recorded, preferably off oxygen before the patient goes on to oxygen. But if the patient's already on oxygen, coming through the door, perhaps with a paramedic, we wouldn't suggest that they are taken off their oxygen for this score. So then what you do is you've got your score for each of the variables, you total that, and that total score gives you a risk. But it also gives you a final total score, which determines where the patient should be managed. We've worked out the cutoffs that can be used. So a score of 0 to 11, the patient can be safely discharged home. From 12 to 26, the patient could be safely managed on a ward. And 27 and above, the patient should probably be considered by critical care. So I'll briefly tell you about the development and validation of the score. So after the case study I told you about at the start, we really decided that something needed to be done about this. And we did a sort of typical clinician type pilot study. So no particular science behind it. We didn't sort of follow any methodological guidance. We just sat down, a group of us around the table, and said, what do we think are the important risk factors for these patients that should be part of our score? And we developed a similar sort of score to this using the risk factors we thought were important. And we did actually get good results. We did see that there were less attendances at the ED unplanned, and a few other sort of better outcomes. But we couldn't really do anything with it because, as I said, we didn't put it together in any sort of scientific way. So we went back to the drawing board at this point, and this really is where my PhD started around probably about 10 years ago now. So this time we sort of followed strict, quite methodological guidance throughout the process. And so the first stage was to complete sort of quite a lot of background work. So we did a systematic review and meta-analysis. We did an ED, a survey of ED clinicians, what they thought the risk factors were. And then we did quite a large retrospective study looking at what the data told us the risk factors were. And at the end of all this background work, you end up with quite a sort of long list of variables that you should consider important to be included in your risk score. Then you move on to the development and validation part of the work. And what that does is you use more data, sort of retrospective data, to mathematically model a proper risk score. And what that will do, will sort of chuck out the variables which aren't significant, and it'll keep in the ones which are. Once you've mathematically modeled your risk score, you then need to validate it. And there's lots of different ways you can validate it, but the gold standard is obviously to do an external validation study. in which you test the model in a new group of patients in a new geographical region. So we did that. This was the final part of my PhD. We did a 7-centre external validation study in the UK, and we ended up with our final score, which you can see on the screen. And the score was found to have excellent predictive capability. So it's a C index of 0.96 with a sensitivity and specificity, positive and negative predictive values of the high 80s and 90s for all. So a pretty good set of results really for a risk score. It's already been further prospectively validated, and I'll cover that a little bit in the next slide. And again, using external validation studies in completely new cohorts of patients. So the science is quite strong, according to what the methodological guidance says. So as I said, as you can see, STUMBL score is a simple tool. And what do I mean by that? Well, there's many benefits, including its ease of completion by the clinician from any profession at any grade, including very early in the triage process as the patient comes in through the door at the ED. It's cheap and accessible. It's just one sheet of paper. It doesn't need any fancy equipment to complete the variables within it, and they routinely collected variables. So we're not asking the clinician to collect anything more than they would normally. It doesn't need any fancy calculations or mathematical genius to add the numbers up. So it can easily be completed after a long shift, perhaps in a busy ED. The other advantage to it is it also includes the lower injury severity spectrum that doesn't tend to be included in other models that are far more focused on the more moderate to severe end of the spectrum. It also includes older, frail, low velocity fall patients, which we're seeing more and more of now in our EDs, not just the young RTC with the urgent thoracotomy or surgical fixation. And it's also used across all patients, not just focusing on one cohort. So some of the other models out there will just focus on the critical care population or motor vehicle accident population, for example. This focuses on all. So as I said, it's been validated externally in the UK and a few times since the original validation study as well. But also now we've completed a large multi-centre validation study in New Zealand. I think that was a 5 or 6 centre study completed about a year or two ago. And that showed that the score in the New Zealand population, the score actually worked well for predicted need for critical care, but less well for the safe discharge home from the ED. But interestingly, it also showed that it worked well for different ethnic groups. In Italy, we've just completed a single centre validation study in Turin, and that was published a week or so ago in Injury. And that showed that the STUMBL score had excellent predictive capabilities in Italy. So whether their health services similar to ours and how they manage the ED or the cohort of patients, very similar to ours, but it actually worked really well there. We're also just finishing up a study in the Alfred in Melbourne in Australia, where one of the physios there, Mel Webb, is looking at validating it for use there. The score has also been taken up by many guidelines, so it's used in the national Spanish guidelines, it's talked about there, it's talked about in the Irish guidelines, the management of blunt chest injury. Most of the UK trauma networks are now using it as part of their blunt chest trauma management pathways. So it would really be fair to say, I think, that unlike other risk scores or risk prediction models for chest wall trauma, the STUMBL scores really started to go external validation on a global scale. So where next? Well, I was just talking to Michael about this at the start before you all joined, and it's kind of been a victim of its own success, really, because the next stage would have been to complete a large-scale impact study, which is what the methodological guidance says you should do next. So we would have looked at comparing the score against no score, but we've kind of run out of control sites, really, because most hospitals that we would have collaborated with for the study are now using the actual score itself. And sadly, we'd actually also completed a feasibility study of this, which was where the STUMBL acronym came from when it stopped being the battle score, as people were calling it, and became the STUMBL score. So it's like I said, it's a double-edged sword. What we will do now is change what we go to do next. So instead of doing a traditional impact study, we will do some sort of evaluation of the tool where it's been embedded in the pathways to see how clinicians like it, whether it's being used the same across different centres and so on and so forth. So I think really the next steps will be further prospective validation. And actually now the tool is nearly 10 years old, so we probably need to think about doing some model update and recalibration. But the other exciting thing that's happened over the last year or so is that it started being used for other things. So we developed the score purely to say discharge disposition from the ED, but now other sites are starting to use it to predict need for regional analgesia. And I know St Mary's in London are soon to present some work on that, which will be really exciting to see. But I know other sites are looking to do the same as well. So that may be somewhere we go next. Pre-hospital conveyance, I've had long conversations and sort of written grant applications with the Welsh Ambulance Service Trust to see whether the score could be used to stop patients being conveyed to hospital by the paramedics. And then the final potential use for it, and this is something more the physios are looking at, is whether the STUMBL score can be used to predict the need for long-term follow-up. So it's got there's a great potential there for the score to have some alternative uses. So it's sort of rolling success really with the model, but obviously the score should be validated scientifically for that use before it is used in such a way. Ultimately, for me, I'd like to see the score embedded into perhaps some sort of big data. So maybe like TARN. So if the Trauma Audit Research Network in Europe, where clinicians are entering their data, so it can be used on a much larger scale. If the STUMBL score was embedded within that, we could do much greater sort of larger scale research work with it. So ultimately that would be good. I've also, I was just saying, submitted it for to be used, so it's freely accessible on MedCalc as well, which would be quite nice for clinicians to be able to access it. And I was hoping to put the link up, but it's not been reviewed yet. So yeah, watch this space for that. And that's it really. I've put my, rather than putting all the references down, I've put my ORCID ID down there where you can pick up all those references that I've talked about. But I've also included my email address and my Twitter handle thing. So if anyone wants to contact me, please feel free. Always happy to have anyone contact me to discuss the score and how it's used. And then obviously, I think we've got time for questions at the end, so we can do that as well. So thank you very much, and I'll hand back. I'll stop sharing my screen. Hold on 2 seconds. Here we are. Has that stopped?
It has. Perfect. Thanks very much, Kerry. You've kept to time, which is a wee Brucey bonus. And just before I hand on to Stella, but my particular interest to take it forward, I think, would be looking at people who are of employment age. Can you predict chronic pain? Can you predict who's going to get back to full employment, you know, in those with multiple rib fractures? But I'm fairly sure that if you get TARN onto that, that will give you the database that you're looking for. So we'll address any questions that come up at the end. So without further ado, I'd like to introduce one of my general surgical colleagues, Stella Smith. She is a colorectal general and major trauma surgeon based in Manchester. She's the clinical lead for the major trauma service in Manchester Royal Infirmary. And of course, Manchester has its own individual connection to major trauma here in the UK for obvious reasons. She is the surgical quality improvement lead for Greater Manchester Major Trauma Network. She's a trustee for the Manchester Advanced Trauma Training, and that's a charity that runs multi-professional simulation and cadaveric training and was developed following the unfortunate and terrible 2017 Manchester Arena attack. She's also a colleague of mine and is faculty in the Definitive Surgical Trauma Skills course, and it was in one of her presentations at a national conference, which led to this invitation today. So without further ado, I'm going to ask Stella to talk us through her perspective on from a clinician's point of view and how we should be managing rib fractures. Thanks, Stella.
Thank you very much, and thank you for having me. I'm just going to try sharing my screen. Does that work?
Yep. If you put it, yeah, that's perfect. Crack on.
Yeah, okay, brilliant. Well, thank you ever so much for having me. It's a great honour to be here this evening, and thank you for that lovely introduction. So, starting off, let's see if I can get my computer to work. Let's see if that. There we go. Yes, it is working. Brilliant. Okay, so when we think about chest trauma, we always think about the deadly dozen, and we think about all these things that are written here on this screen. The lethal 6 are meant to be identified in the primary survey and the hidden 6 in the secondary survey, but actually most of them are surprisingly rare. The vast majority of chest trauma is this. It's rib fractures and hemathorax, both very common. If we think about rib fractures, we need to think about patterns of injury with rib fractures. So with patients coming with ribs 1 to 3 injured, we always think about great vessel or brachial plexus injury. I think great vessel injury is actually very rare. I'm not sure I've ever seen that, but I have seen brachial plexus injuries. We do need to do neurological examinations on these patients. Ribs 4 to 8 are the most commonly injured ribs, and they're also the ones which probably hurt the most, because when you think about the rib cage and the expansion and contraction of the ribs, the movement of the ribs up and down as people breathe, inspire and expire, then actually the ribs 3, 4 to 8 are the bucket handles that sort of come up and they come down, and when they're fractured, they're the ones that hurt the most. So they're the ones that we fix. Ribs 9 to 12, you've got to think about intra-abdominal injury, think about the spleen, think about the liver. Also think about the diaphragm. Of course, we can't think about the chest wall without thinking about the other bones of the chest wall. We need to think about sternal fracture. Sternal fracture is really important because if someone's injured their sternum, we always have to think about the heart which is sitting underneath and what might have happened to that. So always think cardiac effusion in a sternal fracture. Make sure your patient's in and an ECG, and make sure you put them on get monitored for 24 hours, because if they have got a cardiac effusion, they're going to get if they're going to get an arrhythmia, they get it within the first 24 hours. So those patients can go off to HDU for a bit. So why are rib fractures actually important? Well, everybody knows that they really hurt, but the problem is that they do really hurt. And if we don't get on top of patients' analgesia requirements, then what happens is they don't breathe and they don't expectorate and they don't cough. And what you end up with is atelectasis and pneumonia. And then those patients get really poorly. Just as Kerry's told that beautiful story right at the very beginning about her unfortunate patient who died, which led to her scoring system. This is what happens if we're not aggressive with managing rib fractures. Patients can have pneumothoraces. We need to think about the pleural space whenever we think about rib fractures as well. And patients can have pneumothoraces and hemathoraces, usually a combination of both. Pneumothoraces can lead to persistent air leaks, and particularly if patients got underlying lung disease. So an air leak that just carries on and on and on, and the chest drain just carries on bubbling. Hemothoraces can result in retained hemothorax, and that can end up in an empyema. Of course, patients with any broken bone can end up with a non-union. Not all broken bones will heal, and patients end up with a non-union of their chest wall, and that can result in a clicking sensation as they inspire and expire. So how do we manage the majority of rib fractures? Well, chest trauma is managed with a chest drain for the hemopneumothoraces, for the pleural space complication, with an incentive spirometer to expand the lungs, to make the patient expand those alveoli, to recruit those alveoli. So those patients sucking on that little ball thing, machine with 3 balls that you can see there, and they raise the balls. And it's more difficult to raise the 3rd ball than it is to raise the 1st ball. The more balls they can get up, the more they're utilizing their diaphragm and they're expanding their lungs. We give patients chest physio. We're usually quite aggressive about that, especially in rib fractures, to prevent the atelectasis. We give them nebulizers, and we give them nebulized saline as an absolute minimum, and that's to loosen up any secretions and make it easier for the patients to expectorate. And we give them aggressive analgesia. Now, there's quite a bit written about analgesia in rib fractures, and as with anything, there's always a summary guideline, which is really useful, isn't it? So the East Association summarised this guideline in 2016, and essentially they looked at all of the evidence at that point, which is actually fairly weak evidence, but they went through all of it at that point. And the summary that they came to was you need multimodal analgesia from the time that the patient comes in. None of this pain ladder stuff where you give them paracetamol one day, then you give them a bit of ibuprofen the next day. None of that. What you're going to do is you're going to go in with multimodal analgesia from the time that they come in through the front door. Adjuncts to pain relief, such as gabapentin and clonidine, sort of things that maybe your HDU consultants or your higher level care consultants might be prescribing, or your pain consultants might be prescribing. Tend not to prescribe those ourselves, but we tend to start with is paracetamol and opioids. So everybody gets paracetamol, and everybody, even if they're quite old, and you need to bring the dose right down, but even if they're quite old, get a long-acting opioid. And we tend to use oxycodone because it has much less side effects than morphine. What East have said, and what I would completely agree with, is that most patients are going to require some sort of regional analgesia. Now, we're really into doing direct spine blocks because they're dead easy to do. Even I can do them, so they must be dead easy to do. And we can actually even do those on our ward. Lots of different hospitals use different types of blocks, might be paravertebral or intercostal blocks or even serratus anterior blocks. Some hospitals have no access to regional analgesia whatsoever, so they're using thoracic epidurals. But if you're going to use a thoracic epidural, that person needs to be in higher level care, because the thoracic epidural can drop the blood pressure. So multimodal analgesia from the beginning. This is a really massive study. This has got 300,000 patients in it. I mean, nobody else is ever going to write a study that's got that many patients in it, but it's done from the National Trauma Database in the US. And essentially, they came to the same conclusions as the East group did. But what they also said was that, you know, don't rule out rib fixation as a mode of analgesia. In reality, you're going to use what you've got available in your institution to treat your patients. So you come around to see the patient on the ward round in the morning, and you see them and you will need to assess them. So there's three things that I always want to know is, firstly, are they in pain? Well, the minute you go to see that patient, if they're lying in bed rigid as a board and they're refusing to move, they're obviously in pain and they're going to need some more analgesia. Assuming that they can move, you give them the spirometer with the 3 balls and you ask them how much that they can do. If they're a big burly 6'5" builder, age 30, you're going to expect them to get those 3 balls straight up. If they're elderly and frail with some underlying lung disease, they're probably only ever going to get 1 ball up. And so if they can get 1 ball up, that's okay. That's as good as you'd probably expect them to do. Some of this is a sort of common sense approach to assessing these patients. And finally, I see if patients can cough. I need to make sure that they're going to be able to expectorate. That's the 3 things that I do when I assess my rib fracture patients. If they can't do those things, they get more analgesia. And if they're already on maximal analgesia in terms of long-acting opioid, a PCA and some paracetamol, then they're going to go and get a regional analgesia. Or if they've got lots of rib fractures from the outset, they're just going for regional analgesia from the beginning. And again, some of that is, I'm afraid, a common sense approach as opposed to one that's done by scoring systems or anything. Everybody with rib fractures needs a CT chest because you cannot assess rib fractures properly on a chest X-ray. Okay, so rib fixation. How do we fix ribs? Well, there's lots and lots of different ways of fixing ribs, and you can see all these different ways here. The top ones are called Kirschner wires. There's these intermedullary nails. There's sort of various plates and things. To be honest, this is what we use now, and these are commercial plates. This is just one company that makes a commercial system. You've got rose red for the right hand side and blue for the left hand side. And they're supposed to be pre-contoured so that they'll actually fit the ribs, you know, one's for 4 to 5, one's for 6 to 7, etc., etc. But of course, everybody's shaped differently, and you can bend these as well to fit the patient's body. They also make some intermedullary nails, and they're quite good if you've got very posterior rib fractures and you can't fix either side of the fracture because you haven't got enough room on the opposite side of the fracture to put at least 3 screws in. Then an intermedullary nail works quite well. So that's how we fix ribs, but when do we need to fix ribs? So there was a huge amount of debate around this. Okay, this is a patient with a flail chest, as you can see on there. So flail chest is more than 2 ribs fractured in more than 2 places, contiguous ribs fractured in more than 2 places. And you can see that there. That can then create paradoxical movement of the chest. And when you've got more than 2 ribs fractured in more than 2 places, and you've got paradoxical movement, that is a flail chest, and it's actually surprisingly rare. Flail segment is much more common, and you'll see that written all over CT scans. The patient's got a flail segment. What does that mean? Well, quite often what you find is that the patient has fractured their ribs and they've got off-ended ribs in one place, and then they've got a crack or where the ribs are fractured again, but they're in perfect alignment somewhere further around the chest wall. Now, in that particular scenario, the soft tissue will splint the crack, the rib fracture that's not displaced, And actually, if you try to go and fix those, what you find is you have to do a whole load of soft tissue dissection to put a plate on for something that probably wasn't moving that much in the first place. So off-ended ribs have a lot of soft tissue destruction. The whole thing's unstable. They're the ones that you probably want to be fixing, but not the ones where there's just a simple linear cut and the ends are nicely opposed. Flail segment versus flail chest. So start with flail chest, the more rare one. Basically, all of the evidence over the last 20 years really came from the management around flail chest. I do warn you that a lot of these studies do sort of throw in the few multiply rib fractures at multiple levels, and so basically simple rib fractures in with some of these flail chest patients, or some flail segments in with the flail chest patients, and then that makes it sort of interpreting the data quite difficult. But essentially, a lot of the data came around the management of flail chest, and of course, whenever you've got lots of studies, you've got again. So this is the EGS guideline, really nice document. And essentially what they did is they looked at the management of patients with flail chest, with those that were randomized to either having rib fixation or not. A lot of these are prospective studies rather than RCTs, though, I warn you. But what they did find was the duration of mechanical of pneumonia, the length of stay in ICU and in hospital, as well as the mortality, all improved in rib fixation. So flail chest is an almost absolute indication for fixing the ribs. What about everybody else? Murky. So people talk about bicortical displacement of ribs. So you can see in that picture there that those ribs are completely off-ended. That's 100% displacement. 50% displacement is when the rib is moved 50% of the width of itself over the rib, its counterpart opposite it, if you know what to see what I mean. So people talk about bicortical displacement as being an indication. So when there's completely off-ended or 50% or more off-ended. When you've got volume loss or a stoved-in chest, you can see that quite nicely from that chest X-ray there. So they talk about more than 30% volume loss. Of course, you need to do volumetric studies on the CT scan to really be certain what volume loss is, but people talk about stoved-in chest. You can see from that, if that's a young patient, their respiratory functional capacity is never going to be the same as it was previously if that's just allowed to heal naturally. And people talk about respiratory failure despite maximal analgesia. An inability to wean from a ventilator is a really good indication, actually, for needing rib fixation. Okay, so this is a meta-analysis that came out just earlier on this year, actually. And what these people did was they took all of these prospective studies, randomized controlled trials, and what they tried to do was pull out the patients with simple rib fractures alone, not the ones with flail segment, not the ones with flail chest, but just off-ended ribs. And what they found was they really couldn't actually show a benefit to rib fixation in terms of mortality, in terms of tracheostomy rates, in terms of length of ICU stay, in terms of length of mechanical ventilation. So they actually couldn't prove that rib fixation works only. The only RCT that's out there that actually looks at patients with non-flail, so this is non-flail chest, okay, and just looks at patients with bicortical displacement, so displaced ribs, more than 50% or more of the width of the rib is displaced, plus some sort of respiratory failure. And what they mean by that is respiratory rates more than 20, pain scores consistently more than 5, incentive spirometry 50% or below, and they did proper spirometry, not just my, can you get the balls up thing, they did proper spirometry. And what they basically found was that they did pain scores and they did respiratory quality of life scores on these patients. They randomized them to two groups. Some of these patients got rib fixation and half of the patients got managed conservatively. And they did respiratory quality of life scores and they did pain scores. And what they basically found was that their pain scores were definitely lower in the patients who were fixed. There was definitely an analgesic benefit. But the respiratory quality of life scores became non-statistically significant by the time those patients went home. So there was some benefit to fixing the ribs, but it wasn't really conclusive evidence, and it didn't really make a really strong, empowering argument for fixing everybody. They had no difference in mortality, they had no difference in pneumonia rates. So the Chest Wall Injury Society is a group over in America that has a meeting every year, and they've really done a really good job of bringing out some guidance that kind of pulls all of this evidence together. And what they say is you should consider fixing ribs if the patient has got an unstable chest. So they've either got a flail segment or they've got instability in clicking. And sometimes you will feel clicking. You put your hand against the chest wall, you'll just feel those ribs clicking against your hand as the patient breathes. They also talk about fixing ribs if you've got more than 3 displaced rib fractures with some sign of respiratory embarrassment. Okay, so that's your high respiratory rate, your high pain scores, you can't get the balls up on the spirometer, or your incentive spirometry is way below where it should be, or the patient can't cough. Or even better still, they can't get the ICU consultant says to you, I cannot wean this patient off the ventilator, you need to do something about their ribs. They've given a beautiful flow chart for that. I won't labour the point on it. It's easily found on the internet. And of course, there's some contraindications to fixing ribs as well. There's patients who have a severe traumatic brain injury, who are just not going to be coming around anytime soon, who are stuck on that ventilator for a while. Those who've got high spinal cord injuries. And of course, you're not going to be doing rib fixation on patients who are hemodynamically unstable or shocked for any other reason. We don't fix ribs 1 to 3. You can just about get to rib 3. We do occasionally fix rib 3, but we don't. You can't get to what the ribs 1 and 2. So you don't fix those. And the ribs that are floating much lower down, we don't fix those either. So when should patients have rib fixation if we are going to go ahead and fix them? Well, all the evidence for that initially came out of those flail chest patients, that original East guidance that I presented at the beginning. And basically they showed that if you operated on patients within the first 72 hours, you had lower number of days on the ventilator, shorter ICU stay, shorter hospital stay, and low incidence pneumonia. Not really rocket science, is it? This was a really nice study, though, that came out after that at 4 trauma centres in the US. And basically, they took patients who either had a radiological flail segment, a flail chest, or 3 or more rib fractures with some respiratory embarrassment. Those things we've been talking about previously, about not being able to cough and not having your spirometry where it should be, and your the pain scores being consistently high despite having a regional analgesia. And what they did is they looked at when those patients were then fixed. And what they found was that the earlier that you fix patients, they have a lower ICU stay, lower time on the ventilator, and lower pneumonia rates, which is really important. So basically, the earlier you fix patients, once you made that decision, you need to get on and fix them. And the earlier that you do that, the better. What does the guidance say? Do it within 72 hours. Now, of course, the patient's got to be well enough for that. And I think that that's a really important point, because in reality, no 2 patients are the same. He's not going to do very well from rib fractures. He's a big lad. He's not going to do very well, especially also if he's a smoker. He's not going to do very well from rib fractures either. And I think there's definitely an argument for thinking about rib fixation as a palliative procedure in elderly and frail patients. It's what we do for fractured neck of femurs. We know those patients aren't leaving hospital, but they're not dying in pain. And I think there's definitely something to be said for thinking about this as a palliative procedure, even if we think the patients aren't leaving hospital. Patients with underlying lung disease, smokers, are going to do much worse from rib fractures than those who haven't got that. What about the timing? Well, I'm going to present a little case in a second that's going to talk about the timing of when we fix rib fractures. And there are the unfixables. So there's those with incredibly posterior rib fractures where you just have got nothing to put. You can put the plate on one side, but you've got nothing to get to. You can't even get an intramedullary nail in. The costochondral junction is exactly the same at the front. And that's just some more pictures of rib fractures there. Okay, so this is my guy. He's 80. He's from about a couple of months ago now, about 3 months ago, I think. Anyway, he's 80. I'm on call. He's driving his car. My feelings about octogenarians driving cars late at night by themselves is notwithstanding. But anyway, he drove into a lamppost. So here is his CT scan. He's got some free air inside his abdomen. See, I want to tell him how much to get back to the belly, no matter what we do, or what we're talking about. And he's got free air gas in his belly, and he's also got some probable fecal content outside of his small bag. So he's also got this, and this is a traumatic aortic disruption. So what he originally had was I took him, did a laparotomy on him, and we sorted out his small bowel injury, and I did a primary anastomosis. And he recovered well from that, I'm pleased to say. He then went the next morning for a T-bar. So he had a thoracic stent put in through his aorta, and I'm pleased to say that he seemed to recover from that. Days 2 and 3, he was a little bit wobbly. He had a bit of renal failure. He wasn't really reading off the vent. And he took a couple of days really for these inotropic requirements to come down, his kidneys to start working against, by themselves without needing a filter or anything. And by about day 6, it was quite clear that the only organ dysfunction he had at that point was that he couldn't get off a ventilator. They just got him to a point where they couldn't wean him anymore. So he's day 6, he's off his inotropes, he's peeing, and he's got these horrible rib fractures. And you can see the difference in his chest wall on each side there. He had these off-ended ribs. So we took him to theatre, and we took him to theatre on day 8, and day 9, the ventilator came off. So he's someone who doesn't in any way fit into any of the guidance, because yes, he had rib fractures, and yes, he had a respiratory embarrassment, but he was done well outside of the 72-hour window, but he just wasn't ready before that. Okay, so that's rib fractures. I'm just going to touch on retained hemothoraces because that also falls back into what you do with them and when you're operating on patients. So there is no definition of a retained hemothorax, okay? There is not a number which means it's a retained hemothorax, but probably anything more than 300 mils is a retained hemothorax. This is quite an old paper now, it's more than a decade old, but it's a really nice paper because what they did in the US was they had patients who had a chest drain put in. And they just basically observed what happened to them. So they had a chest drain put in, and and when it stopped draining, they sent the patient for a CT scan, and they did volumetric studies of the amount of blood that was left inside their chest. They then followed what happened to those patients. They didn't intervene at all. They just did an observation to see what happened to those patients. And what they found was that the ones that were observed with less than 300 mils in the chest, right, and had no other intervention, did fine. Basically, so if you've got less than 300 mils left in your chest after you've had your chest drain taken out, that's probably okay. You can probably leave those patients alone. What they also found was that those who had more than 900 mils in their chest on that CT scan, you can put as many drains as you want into it, but ultimately those patients are going to end up needing operative intervention. The vast majority needed operative intervention. Interestingly, out of all of the patients that they looked at, there was a 25% empyema rate, which is really, really high, isn't it? So what about the patients who've got between 300 mils and 900 mils? What do we do with those? Okay, so what they found was that for those who had a second chest drain put in, and particularly if that was put in under image guidance, not just blindly sticking a chest drain in, but doing it under image guidance and putting a 14 French in as well, not a piddly little 7 French tiny little pigtail, but a proper 14 French drain, image guided into the collection, they found that 60% of those patients, that was enough. They got the rest of the blood out of the chest, or the vast majority of the rest of the blood out of the chest, and that was all they needed to have done. For those then who didn't get better at that point and who didn't really drain and was still left with some blood and clots sitting around their lungs, there's two options. One is to squirt some streptokinase down the drain to try and liquefy up any clot and see if it finds its way out. Or the alternative is to go for VATS, which is video-assisted thoracoscopic surgery. Essentially, it's like laparoscopy of the chest. So you put a camera in the chest, you put another port or two in, and you wash the chest out. And it's really not that difficult if it's an early haemothorax. So there's various studies that look at comparing squirting streptokinase in versus doing a VATS procedure. And there's another guideline or a summary. And what we find really is that by doing VATS, that patients get out of hospital faster and they're much less likely to come to needing a thoracotomy or needing another repeat VATS at any point. So VATS is better than streptokinase. Streptokinase is good if you haven't got access to theatre, and also if you've got elderly frail patients who you just really do not want to intubate. What they found was that the earlier that you do VATS, so if you do it within 4 days, you've got a lower conversion to thoracotomy, you've got a lower empyema rate, and you've got a shorter length of stay in hospital, unsurprisingly. But really, it's the first 2 days, like conversion to thoracotomy and that empyema rate, where those patients are then going to have long-term consequences from those. That you need to be getting in there within 4 days. And I can tell you from experience that if you're in there within 4 days, you're sucking up a load of what look like little raspberries up your sucker, and you wash it all out, and it all looks lovely at the end, of the lung comes up, and that's the end of it. And it's really easy. By the time you're going in at day 4, day 5, day 6, day 7, you've got a rind beginning to form, you've got loculations. It's much more difficult to know really then whether you need to start thinking about doing a decortication or getting your thoracic there's a lovely little flow chart. There's a number of different flow charts out there for managing these patients. That's quite a nice one for just sort of as an aid memoir. Should we do VATS with rib fixation? Well, there's absolutely no guidance there, I'm afraid, and there is some common sense though probably with it. If someone's got more than 300 mils in their chest and you're going to fix their ribs, then I would do VATS at the same time. If you want to know what 300 mils looks like, well, it just basically blunts your costodiaphragmatic angles on each side on a chest X-ray. So it really doesn't look very impressive on a chest X-ray, but that's 300 mils inside somebody's hemithorax. What's the future? Well, we're using muscle sparing approaches for rib fixation. There are also minimally invasive rib fixations with VATS at the same time. There's a number of studies that are coming out or being undertaken. The ORIF study has been embedded into time, been going for years. The FixCon study is coming out of the Netherlands. and they published their protocol, and that looks really exciting because that is all about what to do with the majority of rib fracture patients who haven't got a flail chest. They're just looking at simple rib fractures, and the SPEAR study is looking at ESP blocks. We definitely need to standardise follow-up. We need to think about pulmonary rehab. I think what we do, certainly in our institution, is really a bit haphazard. So in summary, majority of chest trauma is managed conservatively. Chest physio, spirometry, a chest drain, and some nebulizers. Use multimodal analgesia from the time that that patient comes into hospital. Be really aggressive, and then add in your regional analgesia or epidural, either at the front door or the next day if they're really not coping. The only absolute indication for rib fixation is flail chest, but there are others, relative indications where it is recommended. Don't rule it out as being a palliative procedure, and do take into your mind the comorbidities, and the STUMBL score is great for that. Retained haemothorax, put in a second chest drain, but if there's a lot of blood in the chest, more than 900 ml, send them straight for a VATS. But also if that second chest drain hasn't drained anything very much within a day or two, they need to go straight off for a VATS and get your thoracic surgeons involved sooner rather than later. Thank you.
Thank you very much, Stella. That was definitely a whistle-stop tour around how you manage rib fractures as from a clinician's perspective. So I spoke to the two speakers at the start, and I told them that we had 3 questions submitted to our Ask the Expert email address. And I think it's fair to say, I think probably covered all 3. So the first question, primarily aimed at Stella, was, may I know exactly when to do rib plating? And I think the answer is the earlier the better. I think that's...
Yeah, do it earlier the better. The absolute indications are not, they've still not been synthesized out. We still need more studies with clean patient groups. So it's not, the data's not so heterogeneous. It's still very difficult to know exactly who to plate. But it's your patients with respiratory embarrassment are the ones that you really need to be aggressive with.
And then the next question was also more geared towards Stella. What is the role of thoracotomy in retained haemothorax? And they gave a time frame of 10 days post-trauma. I think you largely covered that, and I would tend to agree VATS versus is much better than thoracotomy.
It is easy. You can teach anyone to do a VATS. I say that, there's been some thoracic surgeons on here now, but you can teach anyone to do a VATS. It is easy. We can all do laparoscopy, so it's easy. Yeah,
I mean, and so I don't do VATS, but I've watched lots of them get done. It's no more complicated than a laparoscopy. And you've just got to get it in the correct rib space. I think that's basically it. And the rest of it is a generic skill that we as surgeons in this audience all have. And then you've actually, Stella, been given a really interesting question by Kerry. So Kerry would like to ask you, what do you think about rib fixation? I think this is fascinating. What do you think about rib fixation in patients with flail chest after CPR? Now, I'm going to assume you've got ROSC.
Yeah, and I'm assuming this is a non-trauma patient, so they weren't having CPR as a traumatic cardiac arrest. They're just
cardiac, a cardiac cause of their cardiac arrest. Let's go for that.
I've never been asked to go and fix ribs on somebody who's post CPR with a flail chest. I'm guessing a lot of the rib fractures in that scenario would actually be incredibly anterior. And probably onto the costochondral junctions, which might make it impossible to fix anyway. The other thing I would say is that when rib fractures are very anterior, they are sore, but it's your posterolateral rib fractures that really hurt, because all the movement of the rib is in the lateral part, isn't it? You think as you take a deep breath, it's the bucket handles of your ribs that come up, and that's the bit that really hurts. So actually, we do fix anterior ribs, often as a part of a flail chest or a really nasty flail segment with 2 off-ended ribs, off-ended ribs anteriorly and posteriorly or laterally. And we will fix those, but often or normally it's the posterolateral ones where you happen to be more aggressive. Does that sort of answer your question? The answer is I don't have any experience of doing that. Well, I have got a patient post CPR who was a traumatic cardiac arrest, who had a flail chest, but she was never, she was on a ventilator. She wasn't going to go for.
I think it's a really interesting question, but tough for us as surgeons to answer because we don't look after those patients.
No.
They go to, you know, a general medical ward, and I've never been asked to see a patient post CPR with rib fractures. Really interesting cohort, actually.
Maybe the medics haven't heard of us yet.
Yeah,
And maybe if they
true.
do, then we'll start getting lots of referrals.
Yeah, no, we've just done one with us. He was a post CPR ventilated on ITU, and we couldn't wean him. And we ended up fixing him quite late, probably about 2 weeks post admission. And he's actually got off the vent and has done quite well, believe it or not. And that's why I asked, because it's probably, I've probably only seen 1 or 2 in our hospital, but they have actually done quite well. And I know the general feeling is that we probably wouldn't. But I've been surprised. Firstly, I've been surprised the surgeons fixed them, and then secondly, I've been surprised that the patient's actually done quite well.
I mean, it sounds. I'm not aware of even a case report on something like that, so might be worth having a look at. But
I think there was a paper published fairly recently. It's the Chest Wall Injury Society who do everything. That's actually that's why I'm in Hull at the moment, ready for they've got a conference tomorrow up here. And I'm presenting in that. So maybe I can ask some of these questions and feedback. They seem to be the experts in the sort of more advanced. They do talk about even fixing costochondral fractures and things I've seen recently. So I think it's a watch this space, to be honest. Yeah. I think it's coming.
Okay. Sorry, I had to turn my lights on. It's starting to get dark here in Scotland, so I had to run away and turn my lights on in the background. Kerry, I have a question for you. Now, I work in an institution that uses your score effectively to triage patients for regional blocks based upon your score. And in short, patients who score more than 15 and are admitted with rib fractures are considered for regional blockade. And like Stella's institution, it's largely erector spiny, and very occasionally the old-fashioned epidural. Do you think that you've got what's your thoughts on that? And do you think you've got data that can kind of support that, or are you waiting on it?
I think it's a really exciting progression of the use of the score, and I think that's probably where it'll go next. So I think we've sort of proven that it works for discharge disposition in most cohorts. Obviously, there's going to be, we haven't done it in the US for their health system is so different to ours. But yeah, so I think we've shown it works for discharge disposition. So I think the next step has to be regional analgesia, and primarily because that's the direction is taken, isn't it? I mean, I haven't sort of pushed it in that direction.
I think
but
so.
People like yourselves and obviously Alex Wickham with you down.
I can give you a little bit of insight because I've seen a sneak preview of the results at Mary's, and I think the magic number was a battle score of 23. And that was the one. So my anecdotal evidence was I always thought that 15 was a little bit low, but from memory it was either 21 or 23 seemed to be the magic number where patients above that score did the best with regional analgesia, and those below, depending on their age, so the younger the patient was, the more likely they were to succeed with just throwing them tablets and incentive spirometers. But I think you can look forward to Alex feeding back to you about that.
Yeah, I am. I'm very much looking forward to that, and I think that'll be where the next grant application goes. To be honest, is to look at validating it for other use. So that's really exciting, and all I can say is thank you for that, because that's sort of been taken out of my hands.
Sure. I can't take any of the credit. It was one of my anaesthetic colleagues who did it all. But I can try, but I'll fail. It's not right.
Yeah.
So it's now 5 minutes to 8. I don't have any further questions, and everybody would either like to go to bed, depending on where you are in the world, or go to work, or maybe end their lunch break. So I think that's a good place to end the meeting, other than to thank our two. Oh, sorry, a question has literally just popped up. So for the erector spiny block, is it a once-off, or is it I think they mean an infusion? Yeah, they've clarified it. Is it an infusion? So in my institution, it's definitely an infusion which runs for up to 5 days, and very, very occasionally more. I personally think that's too long, because both Stella and I come, and most of the audience here, come from enhanced recovery after surgery, and the world where pain analgesia is kept for 3 days, and colorectal surgery has been transformed with that. But in my institution, major trauma patients, rib fractures, they get their erector spinae or their epidural block for 5 days. That doesn't mean that they are kind of pinned to the bed, and definitely inpatients for 5 days, and that's what makes me a little bit twitchy about the duration. Stella, do you have any thoughts on that?
I pull it out earlier if they're doing really well. So if they're not using a PCA anymore, they're not needing any breakthrough. I'm like, I want to get that out and get you moving a bit more. But again, I'm afraid that's very much a common sense approach, as opposed to a nice little flow chart with a protocol attached to it. It's not, it doesn't work like that. And I will leave them in for 5 days if people are really sore. If it means that they get out of bed and they walk around their bed space and they sit in that chair and they use that incentive spirometer. So I guess I'm the same.
So I'll declare I'm a little bit biased on that. I think 5 days is too long, but the presentation that I saw from Alex Wickham and his colleagues seems to actually back up that 5 days is actually better than trying to whip it out in enhanced recovery timeframes. But again, it needs more numbers, probably needs, externally validated. It needs the academics to get at it and to analyze it properly. So that's just, again, it's just single center, probably slightly low powered data, but the proof will be in the pudding, I think, within the next 5 years. So I just want to thank Kerry and Stella for agreeing to accept the invitation. I think it was quite a tough ask to cover rib fractures in less than an hour, and they actually did it in 54 minutes. So the presentation has been recorded. I'll upload it to the TUGS YouTube channel. And once again, thank you to everybody who's come along to listen, and thank you to our speakers, and I'll draw the meeting to a close there.
Thank you.
Thanks for having us.